Okay, so our conference is now being recorded. Again, welcome. Thank you for being here for our webinar about collecting student data to inform our sexual health service programs. My name is Sarah Stahlberg. I'm with the National Coalition of STD Directors, or NCSD for short. And we are the ones that are hosting this webinar today, along with a colleague who I'll introduce in a moment. First, this is the disclaimer that I have to share with you all. Just to note that NCSD is funded by the CDC through the Division of Adolescent and School Health, but we don't necessarily represent the views of the CDC. I'm sure many of you have seen this disclaimer before. So for logistics, just for purposes of staying on track, I'll ask that you hold all of your questions until the end of the webinar. Your lines will be muted, so if you have a question or concern during the webinar, please just type it into the chat box. We've also allotted some time for questions and discussion at the end. And another reminder that this webinar is being recorded, and I will share it with you all afterwards. For those of you, again, who don't know me, my name is Sarah Stahlberg. I'm the Senior Program Manager for Adolescent Sexual Health. I oversee the DASH1308 project on behalf of the National Coalition of STD Directors, or NCSD. So I work with state education agencies on increasing and improving access to sexual health services for adolescents. And I'm thrilled to be joined today by Carlos Romero. Carlos is president and founder of Apex, an evaluation consulting firm. And for those of you who aren't familiar, Apex has over 17 years of experience working with a wide range of programs that address barriers to academic, health, and social success. Evaluation work led to development of data systems, which in turn led to development of the Just Health app, which we'll be sharing today. In 2014, Apex was awarded a National Center for Technologic Innovation as part of CDC's network of STD clinical prevention training centers. Carlos is principal investigator for that center. So our agenda today is pretty packed, actually. I'll review some of the learning objectives and set the context a little bit, and then I'm really going to just hand things over to Carlos to present on some of his work, and then we will open it up for questions and discussion. So because Carlos is an evaluator, we of course have very robust and complete learning objectives for today, and they are identify at least 2 reasons why broad-based risk screening for adolescents in primary care settings and school-based settings is vital for STD education, prevention, detection, and treatment. Identify at least 2 principles to distinguish between effective uses of technology and ineffective uses in a healthcare setting. Identify at least 2 ways a tool like Just Health can address stigma around sexual health for students. Identify 2 ways in which a tool like Just Health can address stigma around sexual health for providers. And identify at least 2 ways in which a tool like Just Health can inform population-level health promotion and program management. So just a little bit again about Apex is funded by the National Network of Prevention Training Centers, or NNPTC for short, which I wanted to spend a quick moment explaining to you. For those who aren't familiar, the NNPTC is a network of training centers created in partnership with health departments and universities across the country. These training centers are CDC funded and are committed to increasing the knowledge and skills of health professionals in the field of sexual health. They have a special focus on STD treatment and prevention. If you're interested in learning more about how the training centers can support your work, feel free to reach out to myself for the SEA partners, or Amanda Brown at CAI if you are a local education agency partner. As DASH-funded partners, the work that we'll be discussing today falls well within your sexual health services approach, but has the potential to also support other areas as well, the other approaches, and Carlos will explain more about that. So without further ado, I am going to ask Carlos to take over. Welcome.
Well, good morning, everyone. My name is Carlos Romero, and I've unmuted my phone, so let me know if you can hear me and if it's clear. I know there was a comment that Sarah's voice was a little muddled, so I'll assume no news is good news unless someone speaks up in the chat room, and that's probably too, as Sarah said, we'll have plenty of time for questions at the end, but if you want to put your questions as they come to you in the chat, then that'll be easy for us to note them and go through them. So my name is Carlos Romero. And what we're going to talk about today is our Just Health app, which is a clinical tool that school-based health centers are using. It's a risk screen. And if I could amend Sarah's title a little bit to focus more on the usefulness of the data than the collecting, and we're going to talk about both. But for us, collecting data is a means to an end, and that end is making it useful for people in different contexts. And so hopefully you'll see some of that today. So as Sarah mentioned, we are a National Center for Technologic Innovation. That's fairly new. We're part of the network of clinical prevention training centers, and we're one of the new national specialty centers that they funded just last year. So there's regional centers that cover the whole country, and then there's national specialty centers, and we are one of them, and we're happy to be part of that group. And the reason we're part of that group is the work that we've done with our Just Health app. So we'll talk a little bit about the evolution of that tool and then try to make it relevant and connect it to some of the needs that you guys have in the programs that you're dealing with. I'm just looking at the chat to see, I think maybe Gabrielle's having a problem, but this would be a good time to say I spent some time earlier in the week with Gabrielle going over the presentation, and she's the New Mexico lead for the SHS DASH project, and so I think she was instrumental in making this a good presentation and making it more relevant to your needs. So as part of our center, we have partners with the University of New Mexico and their project called Envision, the National Alliance for School-Based Health, and one of the prevention training centers out in California. And all of their work is reflected in what I'm going to show you today. And I want to talk about it in terms of three perspectives. Starting with the evaluation perspective, as Sarah mentioned, that's really what we do as we're program evaluators, and that really influenced the development of this tool. And then I want to talk about the clinical perspective, and then we're going to spend the bulk of our time with your perspective, the educational perspective. And I understand from Sarah that there are actually some clinical partners in the audience. I was going to suggest that we go and everyone introduce themselves, but obviously that wouldn't be very practical. But I want to make sure that we're hitting on all these three perspectives. And again, we'll start with the evaluation perspective because that's really how this emerged. And certainly we're proud of our technology, but I think we're not a technology company, or at least we didn't start off that way. We're an evaluation company. And I think it's because of the way we think about evaluation, that's how this tool emerged and evolved, is we have a really high emphasis on making data useful, the developmental aspects of evaluation, making things relevant, and doing it in a collaborative way. And that's, in all of our work with school-based health centers, that's really, that collaboration is what led to the Just Health tool. And a little bit later, you're going to hear some voices from the field, some people that have been partners with us for a number of years. Deborah and Mary will take the floor and tell you about their experiences, and so you'll get some insight from them. And so it started with our work of evaluating school-based health centers. And this is one model. There's lots of other views of the logic model. But one of the some of the questions we had in evaluating school-based health centers are, what do patients look like when they show up at the door? What's actually happening at the school-based health centers? And ultimately, is anyone better off? So those are our three guiding questions that influence the way we evaluate. And when we started doing this, probably 10 years ago in New Mexico, we evaluate all the school-based health centers in New Mexico, all the school-based health centers in Colorado. And when we started off, we were really focusing on understanding what's happening at the school-based health centers, collecting every patient, every visit, every code. And we set up systems to do that, and it was no small feat. We pull from lots of different electronic health records, probably over a dozen different electronic health records, and we have a data warehouse, and we have very good surveillance at a very granular level of what's happening at a school-based health center. And then for the ultimate question, is anyone better off? We also have some tools where we're collecting lots of patient feedback, from satisfaction to engagement to health and academic outcomes. We also collect the data on saved instructional time. So there's a link to how this affects the academic side of things. The contribution that school-based health centers can make, the biggest contribution is they can save instructional time. So that was a big part of what we had. So we had those two pieces well under control, but we really didn't have a good sense of what patients looked like when they showed up at the school-based health center. And we knew that there was a student health questionnaire that was being used. It was a long paper form. And so selfishly, as an evaluator, I said this would complete my trifecta. If I had that data, then I would have the whole data picture. And so we had a grant a number of years ago that allowed us to start to pilot that. And so we created what we called the electronic student health questionnaire. And we basically took that paper form with our partners, made it better, shorter, and then put it into an iPad app. So that was sort of where this whole thing was born. But what we found, and so it solved my problem, right? As an evaluator now I had data for all these questions. But what we found is that the clinical need for this data was also there. The clinicians that we were working with were also frustrated that they didn't have this tool in a very usable format, both to collect it and to use it. So that's when we really started to look beyond our evaluation perspective and started to think about how can we make this tool useful for the clinicians that we were working with. So we came up with some design principles, and we thought a lot, and with their input, about how do we make this user-friendly, efficient and accurate to collect the data. How can we make the payoff immediate, give providers an immediate view of that data that they could use for that visit, and then produce some population level reporting so that the aggregate data was useful for health promotion and population management. And then how do we support integration with other data systems, particularly with the electronic health records. So those were design principles, and then again emphasizing that we want people to use data, and that collection is just a means to the end of using it. And particularly in the health world, this was happening right as electronic health records were coming into play, 5 or 6 years ago, and there was a lot of skepticism because technology was not necessarily working for people. People felt like they were working for technology, and they were worried that we weren't going to solve the problem of not enough time, too much information. So we were very motivated by that to say, no, we want to be mindful of that and to actually solve that problem. And so what we came up with is this little equation, the Just Health equation, of what we want to do is we want to collect new information about student patient behaviors in these different domains, from home and school to health, safety and injuries, feelings, well-being, sexual health, substance use. And you'll see some specific examples of those types of questions. And then we wanted to relate it to the existing information that we had, this body of knowledge around counseling messages, motivational interviewing prompts, clinical guidelines, and make it and customize it for specific providers. And then the result of that is that we could serve up some custom reports, both at the individual level and at the population level. And we'll see examples of all of this as we go through. But this is sort of the premise, is that Just Health can solve the need to make data useful by doing these things. And so what we had early on, remember, we had the electronic student health questionnaire, which was very specific to school-based health centers, administered in primary care settings for adolescents, universally administered, so whether they came in for a cold or a sports physical or family planning, whatever they showed up for, they got this full screen. But in the meantime, some folks back in California, at the California Prevention Training Centers, they're also CDC funded, they saw that and said, can we create a version that is specific to work that we're doing in HIV clinics in San Francisco and other places on the West Coast? And so that's where we created the TASHA, tablet-based sexual history application. So we ended up with these two things as the precursors to Just Health. And remember, so ESHQ is that broad screen for adolescents in primary care. TASHA is very focused for men who have sex with men in HIV clinical settings. And so Just Health ended up being the merging of those two things, as we still held to that adolescent focus. It's broad, but we added some more details around the issues, the areas of sexual health. And so you'll see some of that in just a moment. So here's just a sample screenshot of what it looks like. We'll get into more details of doing a more of a demo screenshot. But this is sort of that first version. It was easy, user-friendly, simple. There's lots of skip logic, so depending on your answers, you get additional questions or you don't get additional questions depending on your previous answer. So this was sort of a view of the input. This is what it looks like to collect the data. And then early on, this was an example of the output, right? That we would generate this immediate alert report, as we called it, that would have every question, every answer organized by those domains, color-coded to risk, and the providers could get a pretty good sense, a pretty at-a-glance sense of what's going on with the student, and that would guide the conversation. So this was version 1.0. But with the TASHA, with the group out in California, they said, well, we want to do that, but we want to add two more things. We want it to not just be a summary of what the patient said, but we want to include clinical guidelines, and more importantly, we want to include counseling messages, so motivational interviewing prompts to guide the discussion. So that really was the next evolution to say we don't want to just summarize what people said, but we want to give some clinical guidance and counseling messages. So that's where we ended up with Just Health. Now, a lot of our school-based health centers, including Deborah and Mary, who you'll hear from in a moment, are still using the ESHQ, but by the fall, we're going to move to where everything is Just Health. So if they're saying ESHQ, it really is, it is Just Health. The difference, other than branding, is that Just Health has that more detailed substance use screen, a more detailed sexual health history interview, and you'll see some of that. So just so you know, they mean the same thing. So what's inside Just Health? A lot of people ask the question, again, particularly those that are in the clinical field. It's based on Bright Futures guidelines. It's based on HEADS guidelines, which covers, home, education, eating, activities, drugs, and sex, suicide, and safety. So you'll see how it follows all of those. It also embedded inside is the PHQ-9, which is the screen for depression, the GAD-7, which is the screen for anxiety, CRAFT, which is your substance use screen, and as I mentioned, the latest CDC clinical guidelines for sexual history, as well as motivational interviewing prompts. So this is where I have to give credit to our, we're the technology drivers behind this, but our clinical partners at the university and the California Center, they're the ones that really make sure that this is filled with evidence-based things. And it's organized around those what I call domains, so home and school life, health behaviors, which you'll see is, diet, nutrition, sleep, safety and injuries, feelings and well-being, sexual health, and substance use. And then we ask some questions about development and future plans. There's a lot of skip logic, so depending on how interesting a student is, it could take up to 15 minutes. Our pilots have showed more 10 to 12 minutes. There's a middle school version, a high school version, and a university version, and it's in English and Spanish. And so those are some of the common questions that come up. So where we are right now is we are in 49 school-based health centers in New Mexico and Colorado, 5,000 surveys at the midpoint of this year have been synced. We're also piloting the TASHA on the West Coast and Just Health in some university clinics on the East Coast. And part of what our work plan is for CDC is to leverage and scale and network and assess, and that's what we're doing here today, and that's what we're doing in some of these pilots that we're working on. But if we step back, I mentioned that ESHQ was born as part of a demonstration grant that we had a number of years ago, and it started off as a small part of that grant and ended up being one of the biggest hallmarks of that grant. So we do have some evaluation data. It's qualitative in nature, but it is to show that ESHQ was instrumental in improving communication, in reducing stigma around sensitive topics, and so that's really how we started to build this momentum around it as a clinical tool, that it could improve patient-provider communication, reduce stigma, and improve the quality of care. And that's what led to our vision. I think I've mentioned that for us, technology is just a means to an end. Collecting data is just a means to an end. So we really want to focus on the idea that we can improve communication, we want to reduce stigma, we want to improve care, and the tools that we've created are designed to do that. And Just Health is really an abbreviation of a bigger vision, and that vision is a world where sexual health is just health, and then by extension, mental health is just health. So we're really driven by this strong vision that everything we do is to reduce stigma, to normalize conversations, and to prepare a provider in particular to have more productive, destigmatized conversations around sexual health and mental health. So that's where the rebranding of Just Health comes from. So let's take a tour. We'll show you some screenshots. I actually added a few more screenshots from my usual tour. and then we'll get to the reports. So even though we're not focused solely on data collection, that is part of what it does. It's designed to make it more efficient, more accurate, and here's some screenshots. So we start off talking about health behaviors. One of the things that we'll talk about later is the idea that it is a broad screen. It's not just a sexual history. It's not just about substance use. I think the idea that we focus on the whole child is part of what gives us a better sense of that person and the intersectionality of issues, but it also serves to reduce the stigma, is that we're not immediately targeting very sensitive behaviors. So we start with health behaviors, like I said, diet, nutrition, screen time, exercise. Then we get into safety and injuries, and these would be more conditions. I think a lot of times we say that it's about behaviors, but sometimes they're just conditions. Are you homeless? Have you been abused in any way? So we do ask those questions, yes or no. Feelings and well-being, this is one of the trigger questions that would lead to the more extended GAD-7 or PHQ-9, depending on whether it's anxiety or depression or anxiety, but these are some trigger questions that they would see. And this is one of the things, this is also a difference between ESHQ and just health, is our providers really wanted us to build those two tools in, and we can score them and automatically administer them when triggers are met. So that was feedback from our providers that led to us including that. And we can come back. I know we're holding questions till the end, but when we're done, we can come back and look at any of these screens or talk about. I'm not showing you every single screen, and certainly you can't see the skip logic that would be in play if you're answering questions in a certain way. So these are just screenshots, but we can come back to these. But I did add a few more on the sexual health because I think when we get to how this is relevant to you and how you guys can use this data and maybe above and beyond data that you have now through the Youth Risk and Behavioral Survey or whatever the different states call them, you can sort of see the level of detail that we go into. So here's a question about attraction. Here's a question about methods for pregnancy prevention, the sexual active and numbers of partners, and who they're having sex with. And you'll see there that we do make that distinction between who you're attracted to, and even before when we ask, do you identify as straight or bi or gay or trans, all those things, we still ask them who you're having sex with. So we know that there's identity and orientation, and then there's behavior. So that would not be a filtering type of a question. Again, we're asking if your partners are both male or female, who your partners are having sex with, if you know, whether you think your partners have an STI, whether or not you're meeting people online, whether or not you're meeting people that are older or younger. These are the types of questions, again, that we're following those CDC guidelines, as well as some other input that we've had from the field. Whether or not you're discussing HIV, STI status with your sex partners. So those were the sex questions. Substance use is where this starts with the craft, so we're asking some of those high-level questions. This could trigger more detailed questions about substance use. So that's sort of a quick run-through of all those different domains of what it looks like from a data collection standpoint. So the real fun begins when we look at, well, what do we get out of that? What are the types of reports? So I'm going to run through 3 types of reports: what you get individually on the iPad, aggregate, and then the reports that you get off of the iPad, logging into our site, or custom reports that we can create based on particular questions. So, and I'm going to zoom in a little bit but this is that high-level view of the new alert report. And if you zoom in, you can see at the top, it is a summary of the student, how they answer the questions. You can see, okay, here's this is a university-age student. Obviously, these are fictional characters. So here we have someone that's male and gay and Hispanic, so you get a sense of who they are. those things are embedded, PHQ-9, CRAFT, and GAD-7 actually get scored. So providers really appreciated this, that those things are automatically there. And then it goes into a summary of every question, every response, color-coded by needs attention or high risk, right? And you can see here examples that they think they or their partner might have an STI, they've had sex with people online, and they've had sex when they didn't want to. So obviously those would be big triggers that needed to be addressed in the conversation. And you can even peek up here and see, that they have triggers around the feelings and well-being section, and that there was, a suicide attempt in the past. So very quickly you get a sense of that. And then here's the third piece. So that's who they are, what they said, and now this is what to do clinically. So some recommended screens and some counseling messages, which are a lot of times are motivational interviewing prompts to guide a better discussion. So that's a sense of that immediate alert report that's instantly available to the provider that they can use to guide that discussion. So then here's a mock-up of a report that's coming soon, and this is a summary for a particular provider. So in this case, a nurse practitioner, again, fictional in nature. If you're a Pitch Perfect fan, you'll recognize who this is. And then it's a high-level dashboard around saying, here's what your population looks like around the big four issues: mental health, sexual health, substance use, and safety. Here's what percentage of your kids have a risk. And then based on who you are and what your population looks like, there's some guidance or recommendations for professional development and recommended resources. So that's something that we're excited about. It's coming soon, but that's another on the iPad report that we want to create to make data useful and very targeted towards that provider. So all of that is on the iPad. It's built into the app. Now off the iPad is where you would get your aggregate, a more detailed aggregate web-based reports. And we're going to walk through this, these screens. So now you're logged into our site, and you could still get that high-level dashboard of what it looks like. Here's high-level what your patients look like. Then, and I should say, this is a fine time to say it, but you probably have some controls over your screen to maximize this as much as possible. So I realize I'm showing you some screenshots, which on the iPad would be perfectly, or on your computer would be easy to see, but on a screenshot maybe not so much. But here's where you get the highest risk questions, and then the total percentages for your site compared to the state, and then compared to, in New Mexico, it's the Youth Risk Resiliency Survey. In Colorado, it's Colorado Healthy Kids, but it's that, the Youth Risk Behavior Survey, as I think what everyone else calls it. But you get to see, here's what your students look like. So here's problems bullying, 36%, higher than the state average of 24%, and higher than the YRS average of 19%. So now you start to get a sense of what your population looks like, and this view shows you your highest risk. Then there's another view that we're working on, and again, these are going to be rolled out in the fall. So Deborah and Mary are probably thinking, wow, this looks cool, how come I've never seen it? Well, this is the next version. And this is what I'm calling the choose your own adventure. And I think this is where it gets really interesting, because then you can start asking questions about what's the relationship between sexual behavior and substance use, or conditions like homelessness or demographics, that you can start to slice and dice the data and start to build your own data picture depending on the questions you have. And again, at an aggregate level with some comparisons. So that's that screen that you would see. And then you have the ability to see every question. If every question is a row with that same your site compared to state, compared to YRS, when there's overlap. There's not always overlap. And so that's what you get sort of on demand that you can pull off the website. We also can pull those out and dive deeper and work on presentation. Here's an example of just the same data, but sort of pulled out in a report that we do. And Deborah and Mary might recognize this. This is hot off the press. These are just going out. And this is another summary. It's basically the same format, but I wanted you to be able to read it a little bit better. So here's feelings and well-being. Here's an example of health behaviors and substance use. So in this case, you can see that this site has more tobacco use than the state average, and the state and mix on the alcohol use, right? More than everyone else in the state, but less than the YRS data. So again, ability to give you aggregate data for comparisons. And then other things that we can create when we have questions, if we want to say, what are the methods of contraception that people are using? And this was from one of our university pilots, where we saw that condoms and pulling out were the primary methods. I mean, there's also the pill, but we wanted to pull those out, no pun intended, and look at relationships between, for those that are doing certain contraception methods, what's the relationship between that, the number of partners they have, and whether or not there was an STI risk. So, and so this was, again, part of a question that this particular client wanted us to explore, but this is relating data across different questions. And I think this is part of the power of the tool, is that we can ask specific questions that cut across different domains and look at that intersectionality of behavior. So a few more examples. I mean, this was another one where we looked at different demographics. So we looked at heterosexual and those that identify as gay and lesbian and bisexual, both male and female, and whether or not they are reporting problems at school, including bullying. So this was an interesting picture, and again, something that you can imagine in your role as schools and in the work that you do around safe and supportive environments, that you might be interested in this data and understanding your population a little bit better. Here's another example of screen time. I actually just saw on Good Morning America today where they were talking about sort of the issues around screen time and developmental and brain function, and so you might be interested to say, what does screen time look like, and what does it look like in relation to physical activity? So screen time's on the left, physical activity's on the right, and we look at it by ethnicity and gender. So some interesting patterns. And so the point here is that you can ask and answer lots of questions, and you can relate across different things. We can say we can relate demographics, conditions, substance use, mental health, and sexual behavior, and ask some pretty detailed questions. And so that's sort of where we're at, where we're focusing on now that we have a system that really does a good job of collecting this data. How do we start making it more and more useful? Which brings us to you. Your education perspective. I think a lot of the things that we've seen up till now, you can imagine that it would have utility for the work that you do. But I wanted to step back and talk about that synergy. I think the reason that CDC was interested in funding us is because we did have a strong relationship with school-based health centers, both in our states and nationally, and that we were bringing them primary care settings, universal screening, where we could focus on early detection, but also prevention and education. And so, I think the data would tell us that of all the new STIs, half of them are youth, and most people with STI don't know they have it. So that's the data that drives us to say we need to be reaching out to youth in primary care settings. They're not showing up with an STI or even a sexual health issue. They're showing up for lots of things in a school-based health center. So that's sort of the synergy of interest with them, and it's working, right? We're starting to build some evidence that we're doing a good job of broader surveillance. It's efficient and accurate. There is more comfort in disclosure, and providers are able to use the data more. So the opportunity now is how's there more synergy with your perspective, with the whole school system? Because we're also joined by a common outcome. We want improved outcomes for youth. We want to address those barriers to social and academic success, including those related to health. So how do we figure out and listen to what you guys need and see if Just Health as it is to what extent can we support you in the work that you're doing? And is there another version of Just Health that we need to think about? So when you think about the data that you need for needs assessment, for education and health promotion, for advocacy, for policy, then that's the conversation that we want to have. So I think now it's where I get to take a little break, and hopefully this isn't too fast and furious. I think we're doing well on time, and hear from a couple of voices from the field. And they're clinical, they're going to give you a clinical perspective directly, where they can speak to how they've used aggregate data in an educational setting, and how that has shaped decisions that have been made. So the first person is Deborah. And when Deborah and I were planning, I said, Deborah, send me a selfie of you right now, and this is what I got, which is completely understandable given this week. But win or lose, hopefully she'll still be smiling, but this is what Deborah will look like on Monday. And so Deborah's going to speak to us about her experiences, and then we're going to hear from Mary after that. And Deborah, I'm told that if you unmute your, if you find your number and unmute it, is what you need to do to join us and present. And then Deborah will have a few words, and then Mary, and then we'll come back and start to wrap things up. There's a few other points I want to make that are specific to the work that you guys are doing in your 1308 programs. So Deborah? I see you on there on the top. Okay, so Deborah says that her mic is on. So you're doing it through the computer, not through a phone? It sounds like. Okay, so if you're on the phone, then I think you just need to find your number there on the list. And maybe, Sarah, do you? I'm not sure.
Yeah, I'm looking for her phone number.
Okay.
Deborah, if you can send us your phone number, I can unmute you.
And just to motivate her to do it more quickly, we'll come back to her Denver Bronco attire.
Can you hear me now?
Yes.
Hello? Awesome.
Good.
Thank you, guys. Yes, I'm very excited about the Super Bowl, win or lose. I love my Broncos. I'm really excited to talk about Just Health today because it's been very impactful on our practice, and it's helped me a lot as a practice administrator. First of all, we found that the students really enjoy filling out the survey on the iPad much more than with a pen and paper survey, and we feel like their answers are more honest. And the skip logic has been great because it's a time saver if there's certain questions that don't apply, whereas with paper we didn't have that option, or at least not as easily as with the technology of the iPad. But we have incorporated into our workflows. We started using the ESHQ as part of a QI project at 2 of our sites, at one high school and one middle school, and we found it to be so beneficial that I've spread it to all of my sites, and we incorporate it in our workflows for all of our well-child checks as well as confidential visits. And aside from the students or patients really enjoying filling it out, and it's easy for them to fill out, my providers love the report. They love having that color-coded report that just pops out at them. What are the areas that they definitely want to address or to tease out more? Because sometimes, especially with the middle school students, they might have some confusion in answering, and so we always want to clarify when there's concerning responses. But that color-coded report has made it super easy. And we, as Carla said, we've used other risk assessments in the past, but having everything combined into one easy-to-use tool has been so beneficial. And especially for the middle school age children, my providers have found that they've identified anxiety much easier using this tool than they have in the past. And so they're able to really find out what are the most pressing concerns and needs of our patients and address them in a meaningful way, which is what we're all about. And as an administrator, for School-Based Health Organization, I meet with school administration on a regular basis, and time is very limited. And so it's nice for me to be able to meet with a principal, show them an aggregate report, and kind of say, hey, these are the issues that your school, or at least from the patients that we're seeing, is telling us, and help them realize what are the areas that we can partner on. And in fact, at one of our high schools, the data was helpful in me convincing him to partner up with a reproductive health program. And so we are now helping them to do sex education in the high school through health class, as well as what we do on a one-on-one basis in the clinic with our health educator. And so that's been very valuable. And one other thing that I just thought about during this call, because I'm in the process of doing our very in-depth funding request for the state, that this tool is actually a very valuable resource to use with funders, because it shows that we are doing in-depth needs assessments with our patients every time they come in, and the aggregate report shows data on 3 different levels. And so I think it's a very powerful tool for that as well. Are there any other things you wanted me to touch on or any questions?
Well, maybe let's hear from Mary, and then we can do the questions. I mean, there's probably 5 more minutes of me, and then we, if you guys can stand by, I'm sure many of the questions will be directed towards what this really looks like in the field. So,
great.
So next up, Mary Hummel, who's up in Fort Collins and works at the Centennial School-Based Health Center. Mary, would you?
Carlos, am I unmuted?
I think you are.
Okay, terrific. Well, hello, everyone. As Carlos said, my name is Mary Hummel, and I'm the center coordinator at the Health and Wellness Center at a alternative high school setting in Fort Collins. We're the oldest alternative school here, and we have a small student population, but to preface, our kids' lives are fairly chaotic. And so the support of having a school-based health center at Centennial to try to help them manage both their medical and their mental health needs, that integrated comprehensive care is really critical in their success. We started using the ESHQ, and I'm really excited to see the new report formats that you're working on right now, Carlos and team. They look terrific. I would echo really everything that Deborah said in her section about the ease of utilizing the tool, the positive reports back from the providers. For us, both the clinical provider, my physician assistant, and my mental health provider, they rave about what they're able to do and the ease of being able to see the information and utilize it. We spend a lot of time also here, given our kids' lives, reinforcing the positive behaviors that those reports show. That becomes sometimes just as important. In particular, into the questions of the sexual health, since that's kind of the emphasis area for you all, I think the reason that the APEX folks asked me to speak on this conference call is we ran a pilot program with our district last summer, and being able to compare the pilot program of the summer, which was focused on any middle or high school student from our school district who needed what they call a sports physical, what we call a comprehensive well child exam, including your sexual health history. We saw in a period of a little less than 3.5 weeks about 90 students from across our school district, 13 of our 15 different schools, mostly low-income students, 70% of them either under or uninsured. So it gave me the information that I needed to make some arguments back to the school district around trying to open up my facility over the school year in total versus just being able to serve the kids at Centennial, and we're in process of renegotiating that with the school district. But from the APEX and the data viewpoint, the amazing thing is to look at the statistics. Carlos showed you the report for Colorado. We look at our home site plus the Healthy Kids Colorado in comparison. And then when I look at my summer pilot program versus my Centennial school year kids, especially in terms of sexual health, the results are really startling. And what we were able to do internally for our kids at Centennial is therefore drive what our quality improvement initiatives would look like, drive what the clinician was providing. You're always going to do, obviously, the top quality care, but the more in-depth information that we're able to do with the students because of the aggregate data. And I'll just give you an example. In 2014-2015, our school population reported of those that took the ESHQ, 88% of our kids had had sex. That is in comparison with the Healthy Kids Colorado, where 40% of the students had had sex. And then if I compare it with the students from my summer pilot program, where'd my number go? It was not anywhere near what the kids at my school were having, and I can't find it really. Let's see. Of the kids that reported for the summer pilot program, 18.4% of them had had sex. So being able to look at that data across multiple different populations, and I really strongly emphasize the pilot program model because my district has been very hesitant for us to expand into providing services for other schools. This has given me the information that I've needed to say there is both demonstrated need and further, if I'm going to segment and look at specific things like sexual health or mental health, these areas in particular for different schools, being able to see that data side by side is an excessively powerful tool. We use that with mental health. We're hoping to be able to, once we see more students from across the district, provide that information back to their home schools so that the counselors or the folks, the health technicians that are working with them will have the information that they need at their fingertips as well.
Thank you, Mary. And like
Sure.
I said, if you stand by, and we'll have some questions soon.
Absolutely.
So I think I wanted to share, I mean, those are two specific examples. I know that there were some others that we heard. You know, we put out the call to say, how do you use this, our clinical users, how do you use this to have conversations with your educational counterparts? And there were other stories that were similar to Deborah's and Mary's, that this is the basis for having that conversation. And it's at an aggregate level that you can share this data and help school administrators and other school staff understand what their student populations look like. So I think that gets us down to, how can this work for you, given the things that you're working on, and my understanding of those 4 areas of exemplary sexual health education, access to services, safe and supportive environments, and policy. And it seems like there's lots of different angles where this data would be useful. So I think we want to get to that conversation and ask you, what are the possibilities? But I wanted to touch on a few other things, because it's interesting, and we've done this with some community school programs years ago, but that idea of what can be shared and how do you deal with this HIPAA-FERPA divide of education and health. And certainly you can share things that are de-identified or that are aggregate. But what's interesting, you can mix visit data with screening data, look at attendance and grades and disciplines. But one of the things that we've done as an intermediary, as an evaluation group, is that we are able to pull identified data from both sides of the house and link them and then serve them back up in de-identified ways. And that has been something that's useful when we want to go across that divide and look at relations between the data, all the data that we've just been talking about, and the educational data that might be available. So that might be one opportunity around the idea that we might need to share data and link them and share them across those things. So I'll plant that seed. I know that there's some other questions that are coming in, and this usually is one of the first questions, is how do we get Just Health? And we are just in the process of moving to where we want to scale this and expand this and figuring out where the place is in the market. So this is where we're at now. It is an annual license. It's an app licensed on an annual basis on a per site basis. And depending on the number of sites that we're dealing with, it's 3,000 to 5,000. And certainly on an economy of scale, if this group wanted to do something even bigger than that, that price could go down depending on how big of a project that we are talking about. That doesn't include iPads, which are about $500 each, and plus the accessories. So if you're talking about tether, cases, locks, keyboards, different people have different configurations on how they have things set up, depending on their workflow. And then there are other options. If there are other data collection tools, consent forms or family histories, then we can talk about that. And I already see that one of the questions, which is usually one of the first questions from the health perspective, is how does this integrate with electronic health records? And so there's a couple of answers. One is that alert report is available as an attachment to be uploaded into the electronic health record, but usually people are not, that's sort of not a satisfactory response. And so we're working on true integration. And I think someone even mentioned that there's a lot of overlap between some of these questions and things that are in an electronic health record. So the good news is that it's not an issue of technology. The technology is interoperable. It's more of a human issue and a funding issue. And so we're working with different EHRs, and we're setting up some pilots and some use cases where we're going to test the sending and receiving of that data using the interoperability standards that exist. So that integration is another area that we want to do, and so that's coming soon. So one of the things that struck me, particularly when I was having this conversation with Gabrielle, who's our New Mexico person, is that if this is what Just Health is now, and you guys, you've seen it, you've seen what it can do. Many of you have school-based health centers that you are connected to that might be interested in this, but many of you don't, and not every school has the luxury of a school-based health center. And so is there a version of Just Health that would be suitable for you, that could be administered in a school setting, that could hit that need of education and prevention, of needs assessment and setting priorities, of going beyond just behaviors and asking about attitudes and knowledge. And so I want to plant that seed as a possibility that we could do that. Think about that equation that we talked about earlier. It really is a universal making data useful equation. We're using it for Just Health in a clinical setting, but the structure is the same. Is there might be new things we want to know. We might relate it to existing things that we already know. And then one of our mantras as evaluators is we want to put the right data in the right hands, in the right format, at the right time. So all of those things could apply to a different version of Just Health for a different setting, a different context. We're certainly open to that discussion. So as we move to the discussion, keep in mind there's Just Health as it is, and then there's all the possibilities of what we could do if there's a need for it. So that's Just Health. It's an app. I think it's also a set of principles for how to use technology, for how to make data useful, for how to visualize data. And it's also part of a movement, part of a bigger movement to normalize sexual health and mental health, to push the idea of destigmatizing these things, and all of this to have that under that shared outcome that we want, which is healthy adults. And as one of our partners says, Jane McGrath, that healthy kids are our only source of adults, are still our only source of adults. So, we have this broader idea that we're part of this bigger issue of healthy kids and healthy adults. So I think that we're doing pretty good on time, a little less than an hour, so plenty of time for questions and discussions. And if you want, I can start with what was already in the queue as I was looking. We addressed the EHR integration, although people, if you have follow-up questions to that, we can handle those. The gender question, we actually do have, it isn't just binary. We ask how they identify, female, male, transgender, or other, or actually we say self-identify. We don't say other. We got in trouble for that. So this has sort of been vetted with that group. And I wish I had that screenshot to show you. And if they choose transgender, then we ask them what sex were you born with on your birth certificate, and then we ask them what pronouns they prefer, so that we're sort of validating. And then, of course, that's separate from asking about orientation, heterosexual, gay, bisexual. So we are pretty mindful of sort of the latest in how to address the gender issue.
And Carlos, can we read the question, since I think you and I are the only ones that can actually see them?
Oh, you mean the screenshots that we looked at before?
No, the questions as you answer them. Just read what the question was as it was asked.
Oh, okay. These questions aren't going for the group. Sorry, I figured we were all just looking at this whole thing. Yeah. So one question was, is Just Health inclusive of gender identities outside of the binary? So that was the question, and the answer is yes. and again, this is part of sort of the feedback that we get from the field and our clinical partners, and running in CDC circles, and even in my evaluation group and the diversity groups that I'm part of, we're sort of in the loop on all of that. And so yes, and then there was other questions about EHR integration, particularly for those questions that are overlapped. And as an evaluator, I like to collect data once and use it lots of times, and not the other way around. Sometimes we collect data multiple times, and we try to avoid that. So we are working on the EHR integration, so that if people are using Just Health, when there's overlap, it flows into the EHR and fills that out. So that's in the plan, but we're not there yet.
If anybody else has questions, please type them into the chat. There's a lot of you, so I'm not going to risk unmuting the lines and dealing with all the background. So if you have a question, just type it in, and Carlos or our guest presenters or myself can answer those. And thank you so much, Carlos, and Mary and Deborah.
Yeah, I hope it wasn't too fast and furious. I actually did a test run and slowed down a lot. Usually I get excited, and so I go faster, but my contact information is there, so if you want more information, then including a demonstration of the app, then we can certainly arrange that. And I don't know how you guys work as a group, but certainly if everyone was interested in doing something that helps us, and we work closely with Dash. I think I saw Sandra on the list, so we're also trying to work within the other networks and partnerships at CDC and also at NCSD, and I appreciate Sarah for inviting me to do this, but we definitely want to support you, and I think CDC would be interested in seeing us do the type of work that we're doing even beyond the school-based health settings and just in the school settings.
So we have another question from Tim in LA. Are there other ways to use the data for evaluation, like prompting client to be in a study and putting them into a randomized sample?
Well, there isn't. That is not built into the app where the client would actually get feedback, which is actually, one of the things Just Health really is about, making it easy for patients to submit that data. And then it's the providers that we're giving them the reports to support things. But we're actually looking at another version, and we just applied for another big grant where there would be a version that students would do on their own. And that might relate to the question of are patients in the loop about getting the feedback and getting referrals or links to resources. But certainly if you were looking at doing that, you could use the data to follow up and use the data to do some sort of a randomized study. But that's not built into the app itself, and there's no prompting back to the patients. In part because, we're that the idea of asking a high school student, do you want more information? Can we text you? There is that issue of confidentiality and that we need to be sensitive to. So we're still kind of working on that issue of getting patients in the loop. So I think there's another question about purchasing the app. So I think we had that screen on pricing, and so I think if you're interested, you would need to call us and set up a demonstration, and that includes, I think there was another, how much training is involved per site, in what format, and does it come with the cost already? Yes, that licensing does include the setup and the training, which is web-based, but we also do a lot of phone support and tech support. Maybe Deborah and Mary could speak to that, but that does include, it's the license including setup and training and ongoing support.
And I would also add, if you are interested, you can contact Carlos directly, but if you're a local education agency, I would keep Amanda in the loop, just to let Amanda at CAI, just to let her know that this is something that you're working on. And if you are a state education agency where your districts are interested, just keep me in the loop so I know that this is something that you're working on and can support that process.
And so the other question, does the price include upgrades each year? Yes, we are trying to work on having everyone on the same version, and I think that's part of, my agenda is the more people that are using it, then that gives us revenue to keep adding these features that we want and that people want, and everyone benefits from that. So yeah, the idea is that price would always keep you with the latest update. Let's see. I think it says offline, but how to use tethers and iPad locks. And you just want to know where? Yeah, if you email me, I'll tell you where. But to that point, I think we've not lost. Well, I know that we have not lost an iPad to theft. And maybe Deborah and Mary can talk about how they do it. It depends on lots of things. The setup. We have some school-based health centers where the front desk is in the main hall, and so they have it locked and tethered, and the waiting room's kind of there in the hall. And others are a little more self-contained, and they don't use. They use a case, just an OtterBox, but it's not locked or tethered. So depending on your workflow, there's different things. But we found that we were worried going into this with that big federal grant that this could go south pretty fast if they start disappearing. But we haven't had that issue.
Can you hear me, Carlos?
Yes.
I not hear.
It's Deborah. I was just going to add to that comment that, yeah, we have found that the iPads have been very easy to maintain in our sites. When we originally implemented, we did have the full-on tethers and all the gear and had them locked down. But we found that most of the kids, at least, are so used to using their phones or different technology that it really hasn't been an issue. They fill out the questionnaire, they hand it back to their medical assistant, and we do try to keep them, in the provider office out of sight when they're not being used. But we just use it as part of our normal workflows, and we haven't had any issues with them getting lost or stolen or damaged. Thank goodness.
Yeah, we were pleasantly surprised. I had a feeling. I had seen some other research where people are saying, oh, you can't, if you give kids technology, they'll break it and steal it. Particularly, higher risk, populations, which is where our school-based health centers usually are, with higher poverty and that sort of thing. So I was happy that we can still say that we haven't had that problem. So someone asked a question of whether or not this will be used on a mobile phone as well eventually. So there's two answers. One is that version that would be more of a personal standalone version of Just Health that students would take. And by the way, that was one of the things that the National Alliance wanted, because everything that we've showed you, students one way or the other are showing up at a school-based health center, not necessarily for family planning or sexual health, but for some reason. So what about all the kids that are not even linked to a school-based health center or know that there's one? That's that version, and that will be phone-friendly, where someone would take it and then it would tell them and say, here's where you can go for services, or here's the information that you need for whatever your responses were. So all of that will be on mobile phone. But right now, the tool is really designed to be used in the clinic on a dedicated iPad, not necessarily dedicated to Just Health, but dedicated to clinical use. So it's not intended to be on a personal device of any kind. So that's sort of the workflow and the setup now. But certainly when we do a student version or a patient version, it'll be mobile phone friendly.
And Mary, it looks like, did you want to add something?
Yeah, can you hear me?
Yes.
Great. I just wanted to add in two things. We also have not had any issues with the iPads wandering any further. They're integrated into the workflow with both of the providers, and it works out quite nicely. The other thing that came up in a previous question was around Apex and the cost and the support. I want to give a big plug to the folks at Apex. Not only are they always available to us and willing to customize things, the ability to work with someone who, or multiple individuals who are experts in what they're doing and really driving towards the same quality of standard of care and support that you're driving towards is really monumental. It's been a phenomenal working relationship. So kudos to those folks, and again, really excited to see the new products coming out because I think they'll make a even bigger impact than what we're experiencing right now. But Apex has been phenomenal to work with, and I just want to give them the credit that they deserve.
I totally agree. This is Deborah. I totally agree with what Mary said. Apex has been a great partner, and for us that's so important because we are on a very tight budget with a very lean staff and no IT department, and so having Apex being extremely responsive, whether it's having issue syncing or having suggestions on the content, they've been very responsive and very supportive. And even back in the beginning when it was a little daunting, when we pulled the iPads out of the box and told the providers how they were going to start using them in their visits, they were a little taken aback by that. But with all of the support and encouragement that we received from Apex, that made this much easier for us to implement, and it made it a positive experience for them, which helped me to spread it to the other sites.
Thank you
Great.
for that. And I think a lot of
Thank
that
you.
is, I think that coming at it from an evaluation perspective first and a technology perspective second is I think part of what drives us to support users and to look at it as a partnership. And so I'm glad that you guys are feeling that. So a few other comments. How many iPads are needed per site to not create a backup? So what we did when we started off with this grant, we gave everyone 2 iPads, and then I think we ended up going up to 3. And all of the iPads can be both intake and provider. So the intake is what the patient's using, and provider is pulling up a report. And so some of them do 2 intakes and 1 provider, 1 intake, 2 providers. It's very flexible, and everything syncs across, and there's security built in to get in and out of the secure section. Then our university clinics, though, we were sort of surprised as we moved to that, where they were saying 3 is not going to cut it. We need like 8 to 10, and so that's sort of the workflow that they're using. So it sort of depends on your context, but knowing that any iPad can be both a provider or an intake, and you can change them throughout the day, right? You can have all 3 of them as intakes, and then providers could take those iPads and use them. So lots of flexibility in terms of the workflow. There's another question about an app that already does this, and certainly there's the whole world of mobile health technology is kind of exploding, and we're part of that. But the idea of a clinical dashboard for a medical record, that's one of the things we're talking about as we've gained some interest from, the CDC centers kind of elevated us and given us some credibility and given us some attention. And the idea that this, if I understand the question, that this is kind of a plug-in for any medical record is definitely something that we're pursuing. Because you're right, that there's lots of similarities in terms of data collection, although ours might do it a little bit differently, but it's collecting the same data. And on the outside, though, I think our reports might be the same information, but maybe structured differently, to have different ways to create your own reports, different other data sets that we're integrating. So I think on both outsides of the bookends, there are things that are unique about Just Health, but there's lots of overlap, and certainly we're collecting a lot of the same data. So I think that's the dream as we scale this up, could be how do we work closer with EHRs, including develop a version that kind of sits right within inside the EHR. And so if I understood that question, Robert, it's definitely on our radar. So let's see another. So right now, Timothy asked the question of, on intake, do students get prompted with anything educational or resources? And no, right now the answer is no, but that's also on the radar. And that's that other version I was telling you about. Right now it's sort of like, how do we get more efficient and make a visit better? So it's linked to a visit. So we're relying on the provider to kind of fill in those gaps of education and resources and guidance. But we definitely want to build in and get patients in on the loop and that's another version that's in the works.
Do we have other questions, thoughts?
One of the things I always say, and I think you can sort of see from the types of questions, is that I think that we're still at the point where we're looking more for partners than necessarily where we're just out looking for customers. And I think that's our perspective, is that we're still, and you guys are a good example of saying, does this work for you? How can we make it work for you? Is there a whole other version that would work for you? And so that's sort of where we are in our evolution of this app and other possibilities for apps. So we're definitely open to feedback and suggestions and figuring out how we can work with you individually or even better as a group. So I think I've gone through some of the questions. If I haven't, raise your hand again virtually, or ask the questions. But
Well, thank you, Carlos, and thank you everyone for joining us today. As I mentioned, I will share the recording, and then I can share the slides as well afterwards, so that if you want to go back and re-review and send some follow-up questions, I think we're open to that. And again, if you do reach out to Carlos, just loop me and or Amanda in on that conversation so that we can better support you as well and be a part of that planning. And I can leave this webinar open and the line open for a little while longer if you do think of some more questions. But otherwise, have a great afternoon, and thank you again.